On attend 2 minutes ou je démarre? On attend 2 minutes?
Commencer à prendre la parole pour que les gens puissent parler.
Ok. Allô? Good evening, everyone. Thank you for being present here for the Electa Symposium. I will start by introducing myself. My name is Aitem Ben Abdallah, and I'm the BU manager for Electa French-speaking Africa. I'm really glad being here today with this great and fantastic event with all of our customers and maybe future customers. So we're really glad to serve you. I will not be doing a presentation or a corporate presentation because this is really a scientific presentation. This is how we want it to be. I will be just saying some words about Electa and introducing our guests for the presentations. Electa, I think it's really important to remind that Electa is a company that have been created by neurosurgeons, Professor Lars Lexell. That was like 40 years ago. And the existence of Electa as a company have been done and created to serve neurosurgery and to serve the neurosurgeons. And the first machine that have been created it was really a great innovation and is still a big innovation is the Lexell Gamma Knife, which is the unique and the more precise and accurate machine for treating brain. This is really important to remind because now that we have a lot of competition turning around this market and saying a lot of things about neurosurgery, it's important to keep in mind that the only things that matter is the patient, the precision and the accuracy of the treatment. And our Lexell Gamma Knife system is the unique and the most accurate and precise one on the market. On top of this, of course, we have been developing our activities across the last years by very strategic acquisition that have been made by Electa. Well, the most important of that acquisitions was the radiotherapy field, where we are present since the 80s with Philips. We bought the Philips radiation therapy techniques, and we developed this, and now we are having also the high-end treatment LINACs, or linear accelerators, that are very also precise and accurate for radiosurgery outside the brain. And this is something that we as Electa want to really promote. The gold standard in treating brain is the Gamma Knife. And when we want to be more general and treat other body sites, then the LINAC is accurate as well, and we can do radiosurgery and with it, and stereotactic treatments. So we will be today seeing two presentations about this fantastic Gamma Knife machine. The first presentation, in the program we were starting by Professor Wael from Egypt and then Professor Melhaoui from Rabat. They will be sharing with you their experience with the Gamma Knife, but we will be switching these two programs. So Professor Melhaoui will start first with the Rabat feedback on using the Icon Gamma Knife. So in Rabat, we upgraded the Gamma Knife to the latest stage today, which is the Icon stage, where we have now what we call into Electa the adaptive radiosurgery with the imaging on the Gamma Knife. And by the way, these adaptive treatments are now the the new mode. And this is really the vision of Elekta for both radiotherapy and radiosurgery, is to bring the adaptive and the motion management on the machines. And in the radiotherapy, the last born LINAC is the MRI LINAC, where we are now bringing an MRI tool on the LINAC in order to follow up the targets. So for the gamma knife, I will now leave the stage to Professor Melhaoui, who will tell us a lot about science and clinical evidence in using this machine. And then, of course, Professor Adyl will take over from Professor Melhaoui, sharing his experience in Egypt. Thank you again for your presence. We really appreciate, and we are proud being here with you. Thank you.
Thank you, Ms. Haytham. I want also to thank Professor Abadi, who introduced this session, and thank the team from Elekta for being here and to be our partner in this meeting. As a treasurer of the Moroccan Society, we thank you. And I will be talking here about our experience with the gamma knife surgery. Since this year we are at our 10th year of this kind of treatments, and also bring some data about our more recent experience when using the gamma knife icon. So as all of you know, gamma knife radiosurgery has started quite a while ago with Professor Lars Lexel in the 60s of last year. And now it is widely acknowledged among neurosurgeons as a neurosurgical tool that is used daily. So radiosurgery for neurosurgeons and for patients is quite attractive, since it is a kind of surgery without anesthesia. We are doing a kind of closed skull surgery, so it looks very attractive to the patients. And in the pan-Arab world, in our area, when we try to have this kind of technology, there are some problems that we have to deal with, like the cost of the equipment, the access, the health access of the population, and also sometimes the choice of the equipment can be quite problematic, and this can be discussed. So in our context, and thanks to our mentor, Professor El Khamlishi, and our foundation for curing health system nervous diseases, we could get this machine. So we had the installation of our gamma knife unit in June 2008. And first patient was treated within days after the installation. And from this period, we have treated up to now more than 1,600 patients. And you all know that the radiosurgical procedure is quite straightforward with this 4-step local anesthesia. And for children, we may use general anesthesia. And here you see our anesthesiologist doing that. Regarding the caseload, we have started the first year around 100 patients, and slowly our numbers grow to 200 and then stabilize. So right now we are doing about 200 cases. The worldwide average is about 250. Age distribution, you see it's mainly young adults. And regarding this point of medical coverage, you see in Morocco, we have about 50% of patients that are benefiting from these treatments with medical coverage, while there is about 44 that will pay themselves for the treatment, and our foundation also is participation by taking care of about 3% of these treatments. So regarding referent doctors, when we look, we have mainly a referral from the team in Rabat, from our colleagues in Rabat, but also from other specialties. But we see that the referral is mainly neurosurgical referral. Regarding this specialty, you have here the specialties, so mainly a neurosurgical reference. And from the point of view of origin of patients, we see that gradually all neurosurgeons in the country, and we thank them for their trust in our unit, has been involved and are sending their patients today. Of course, Rabat and Casablanca comes first, but we see all cities of Morocco are represented. The same in the region, since we are the only center in the region, a lot of colleagues and patients are trusting us, and we have treated quite a big number. Some colleagues are here from Mauritania, Algeria. We thank them to trust in our unit, and we are taking care also of their patients. So again, back to the indication, when we start, we have to pay attention to the indication of any of our techniques, and here the multidisciplinarity is mandatory. As you all know, a fool with a tool is still a fool, so this we have to keep in mind when dealing with indication. Here, of course, you see cases which are absolutely not indication for radiosurgery, but this you all know. Our cases are presented like this. We see that it is mainly AVMs we are treating, then benign tumor meningioma. Metastasis comes in terms of pathology also. This is the distribution, the percentage. Again, when we group the benign tumor, this is our first indication, but when we take each pathology, it's the AVM that comes first. So some illustrative cases just to give you an idea about what we do. Regarding the AVM, we have discussed a lot in the vascular sessions here in the Congress about this. What we have noticed that since the introduction of these techniques, a quite big number were treated, and you see here that after introduction of this gamma knife radiosurgery, all patients could be treated on-site in Morocco, while before there was a subset number of patients that had to be transferred abroad, but now we are dealing with all of them. This is some of the results. You see disappearance of the AVM after 2 years. Here, a complete cute angiography of an AVM after 2 years, which are common pictures you see. And of course, this is surgical treatment, so you can have still some complication, but you see the numbers are very low. In the case of IVM, also was discussed in the vascular session, this problem of rebleeding, but in our series, it's not more than 3%. A benign tumor, we saw some interesting volume reduction, volume control for most of our cases, and we almost had this kind of cases that made one of my colleagues say, oh, Professor Melhaoui, we will not operate anymore if you could doing this. But again, this is just a tool for neurosurgeons. So these kind of cases, we do what we call combined approach, which means surgical removal first, and then, of course, the remnant can be treated, and there is still room of both technique. This is a case of vestibular schwannoma. This is a pituitary adenoma that has been on the cover page of one famous published book from our center, and the brain metastasis. And this is really a revolution in the field the last years, is the treatment of brain metastasis. Taking an example, this patient, she is the wife of one of our professors of pediatrics in the university. And we have treated her like 7 years ago, and till now, she is perfectly controlled and doing very well. You see, whatever is the number is no more a limitation. We can treat perfectly with this technology. Some functional we did, like hypothalamic hamartoma, with very nice results. You saw Professor Hamlishi showing some of the results. And of course, trigeminal neuralgia, even VIM thalamotomy for radiosurgery we could do with very good results. And we have conducted a few years ago, one of the students, an independent assessment of patient satisfaction survey. So the overall global experience, 86% of the patients declared to have a good experience, and 7 an acceptable, while 7 declared keeping quite bad memory of the experience. Regarding patient information, 84% were considering to have been given enough information before treatment, 14 also was satisfied, and only 2% declared that the information given was not in accordance with what they have been gone through. The global opinion satisfaction was about 92%, and 93% of the asked patients were keen to recommend this treatment for their relatives if an indication were there. So in summary, regarding this experience and the field, what we have seen of changes since the beginning is that now, for the multiple metastasis, there is no room anymore for whole brain radiation therapy. The combined approach tends to reduce the surgical morbidity, and there is a huge also development of the functional radiosurgery. So our 10 experience confirms that the Lexel Gamma Knife is a very useful, minimally invasive technique, widely accepted among neurosurgeons nowadays, and is life-changing for many patients. And we just had our 10-year anniversary last June. So I will move now to the second part, which is about the icon. We were already on perfection. So what pushed us toward changing more than perfection? We are human beings, we always want more. So what we are asking for more? We had the upgrade and change for the icon in February 2017, last year, with a reload. So more than perfection, we could be asking ourselves, is it, do we need fractionation technique? Do we need stage technique? Do we need to do frameless techniques? And we know the icon can allow this. Treat maybe larger lesions and lesions that are close and involving critical pathways. It is mainly the optic pathways. And we can discuss about some oncologic applications. So these are maybe the goals or the objectives of such a new device. You all know about the historical evolution of the technique since the beginning in the 1960s, the Model U, till 2006, the perfection, and then nowadays, since 2015, the introduction of the Gamma Knife icon. And the Gamma Knife icon I will present now to you is based on the previous generation, which is the perfection, but will add the imaging with the stereotactic CBCT and also one camera for motion monitoring and also the capability of frameless treatment. We will see this through this video that will take some time. I will try to comment on it. So this is the new machine. Again, it's based on the Gamma Knife perfection, which is mainly the moving, robotic moving couch and the irradiation unit that has always also been upgraded and integrated robotic. So here is the frame. You see there is a headrest and a thermoformable mask that will keep the patient steady during the treatment. So first phase is the acquirement of a stereotactic CT scan thanks to the CBCT that is integrated, you see there. And this generated stereotactic CB scan will now stand up for the frame. So these pictures are sent then to the treatment planning system. And from the treatment planning system, we will be able then to merge and to fuse what we have designed as treatment before and see the correlation and how it fits on the patient that is there on the table. So when we are satisfied, we will then apply the treatment, and you see that the patient during the treatment is monitored regarding his position thanks to this camera, which is a high definition, and we are able to check if there is any change of position. Usually, we can fix the limit up to 1 millimeter, 1.5, depending on the clinical situation we are. But this gives you an idea about how precise this system can be. So this is how it works. You see here the irradiation unit with the changing of the colorimeter and the source that are moving, and this is how it works. So with this tool, now we are able, and we have changed this classical workflow we all know, because we are no more obliged to do the 4 steps in a row. We can do them in any way we can, and the possibilities are just multiplied. So again, we can talk about the classical workflow. For example, we put on the mask, we do the fusion, we check if the fusion is correct, what has been called as adaptive treatment, and then the patient is laid on the table with the camera that is monitoring the movement to check he will not move during the whole session of treatment. We can discuss some points regarding these technological aspects of the icon. What about the frame and the mask? I think it's a matter of accuracy. You have to be aware as neurosurgeons that when you move from the frame to the mask, of course, it can look less invasive, but it's also less accurate. And you have to think about it and to have this in mind. If you are about to treat one trigeminal nerve for trigeminal neuralgia that is about 3-4 millimeters, if you have inaccuracy of 3-4 millimeter, which is given by the frame, you will end up with an error on the dose about 80%. You have to pay attention to this. So another point I want to underline is regarding single session and fractionation, and maybe Professor Adyl will talk more about this, is that radiosurgery by definition is the single session treatment. And we have to differentiate from the radiation therapy, stereotactic radiation therapy, and radiosurgery. When we are doing stereotactic radiosurgery, we are treating as the surgery do. We treat only the lesion. When they do radiotherapy, they will treat the lesion in such a way, they treat the lesion and the surrounding structures, and they need to fractionate to spare the surrounding structures. So this is called biological difference. There are bases. We have to know all this technique, what is radiosurgery, what is the other techniques of radiation, and the precision is not the same. There are radiobiological bases of this. I will skip this part. And again, to come back to the cases for fractionation, we already did some fractions with the gamma knife with the frame, like stage radiosurgery for large lesions, and also for lesions that can be close to the optic pathway. The capabilities, the dosimetric capabilities of the gamma knife allows to perfectly spare the nerve even if the lesion is very close. So this is one point. You see here, for example, a case of optic nerve sheath meningioma with still functional. This was treated with the frame at the era of the frame. 3 times 6 grade, patient is controlled and no vision loss. Same case, same thing in this case. So our experience after 1 year is about 213 cases treated, and you see that the frame-based single session is still 169 cases, and frameless cases are about 19%. And in this 19%, you see that 40% of them are still single sessions, and we do fractionated hypo or either normal in the other percentage. So the modalities now we have are really multiple: staging, volume, staging of the lesion, the hypofractionation, the normal fractionation, retreatments. So all this has been possible thanks to the new approach of the icon. Here are some cases. This patient has been operated on by Professor Al-Khamnishi something like 20 years ago, parasagittal meningioma, recurred once, and he was followed. And you see here that we have in blue a previous treatment of the gamma knife, and you see there is almost no more lesions there, but then there were some new lesions that appeared, and this we could treat frameless in single session. Case of multiple metastasis, you see here the strategy of the staging of the dose in metastasis. These were 2 big metastases. We did 1 fraction, waited for a month, and here you see the results in 1 month. There is a shrinkage of the lesion, and then we can complete the dose. A few words about our experience with normal fractionation in glioblastoma. As you all know, we have to stick to the STUP protocol, which is the only available now, and we tried in 11 patients to apply this. The advantage here is that the patients will stay within our neuro-oncological units, and they are taken care inside the neurosurgery departments. So these are some cases. We see quite interesting results, mainly that it is much more aggressive than radiotherapy. There is volume shrinkage in all cases, or they are controlled, but more, they are improved. I don't have experience with a patient that was sent to radiation therapy for glioblastoma and came back better. Here, when they start their treatment, at the end of the treatment, they are better. So this needs to be investigated. This is in favor of these patients that we all know that the prognosis is quite bad. So our comments on this short experience is that the introduction of the icon is clinically relevant. There are some, I would say, technical limitations, but these are more like details, maybe for a message to Elekta, so that we can still try to improve this treatment, but certainly it adds a lot to our practice. And what we see in conclusion is that the gamma knife icon is a neurosurgical tool in the lineage of its predecessor, and it allows to broaden the fields of application of this technology, allowing more patients to benefit from its high efficacy and innocuity. And I cannot finish without thanking all the team, all the partners, the neurosurgery departments in the hospital, and all the other colleagues that work with us. Thank you for your attention.